Good morning. I'm Dan Martin, Provincial Director of Pharmacy for BC Renal and Chair of the Pharmacy and Formulary Committee, and I'll be moderating this session. I really appreciated Timothy Caulfield's session this morning and the importance of relying on evidence and science to direct decision-making and to help us have informed good care for our patients. And with this in mind, it's important to evaluate new therapies fully. Often this involves going back to first principles, to basic principles, and to reevaluate and understand and update our knowledge about all the available therapies and methods to treat a condition. Only by doing this and by doing a deep dive into the evidence on these new therapies can we weigh the benefits and costs to make formulary decisions and to decide which is best for our patients. And I'm thrilled to, with this in mind, to introduce our speaker. Dr. Palmer is a tenured professor of internal medicine at the University of Texas Southwestern Medical Center in Dallas, Texas. He has authored more than 260 articles and chapters and served on the nephrology subspecialty board for the American Board of Internal Medicine, and he's a designated distinguished teaching professor by the university. And I'm sure that if you pay close attention, you'll want to watch this talk again and again, perhaps. And so I'm thankful that it will be posted on the website after BC Kidney Days. And with that in mind, I'll mention that today's talk, Evaluating Treatment Options for Hyperkalemia, has been a leading topic at American Society of Nephrology meetings and other meetings, and continues to be an important subject of conversation. We felt it was important to have the options for hyperkalemia discussed at this year's BC Kidney Days. And I'll remind you, if you have questions during this talk, please use the Q&A section to post your questions so we may address them after Dr. Palmer's talk. Now, please join me in welcoming Dr. Palmer, and thank you, Dr. Palmer, for your time today.
Well, thank you. My name is Dr. Biff Palmer, and I'm a professor at UT Southwestern Medical Center. And I want to thank the organizers of the meeting for allowing me to make this presentation that I've entitled Evolving Treatment Options for Hyperkalemia. Now, I would argue that potassium disorders are some of the more common electrolyte disturbances that we encounter both in inpatient and outpatient care. And so I'd like to begin by just overviewing some issues with regards to normal potassium homeostasis. Remember that in a typical 70 kilogram individual, we have roughly 3,500 milliequivalents of total body potassium. Most of that is found in the cell, primarily in skeletal muscle. And we only have about 70 milliequivalents in the extracellular fluid. And it's this large inward to outward gradient that's the primary determinant of the cell voltage. And this is why disorders of potassium typically cause manifestations in excitable tissue like neuromuscular tissue or the myocardium. This is just kind of an overview of K homeostasis. Let's just say that somebody's ingesting 100 milliequivalents of potassium. The kidney is the main route by which we maintain total body K content constant. But there is a small contribution of the gastrointestinal tract. In the colon, about 10% or so of potassium is excreted from the body. Now, the kidney's ability to excrete potassium is not instantaneous. It takes 3 or 4 hours following a large K load. So to guard against excessive rises in extracellular fluid concentration, there's initially a shift of potassium into the cell. This allows then enough time for the kidney to excrete that potassium load, but guard against excessive rises in the extracellular compartment. So it's very important to have this ability to distribute potassium quickly within the body compartments. The two most important factors involved in shifting potassium into cells from a physiologic standpoint are insulin and beta-adrenergic stimulation. So when we eat food, we not only release insulin to control the plasma glucose, but insulin, again, it plays a major role in shifting that K load into the cell, once again, to allow the kidney enough time to excrete it. Beta-adrenergic stimulation probably is most important under conditions of exercise. When you exercise, potassium actually accumulates in the interstitial compartment of skeletal muscle, where it exerts a vasodilating effect. and that's appropriate for exercising muscle. But obviously you don't want too much potassium accumulating outside of the cell. So as we activate autonomic nerves through beta stimulation, that keeps the amount of K that's exiting in check. By the way, this vasodilating effect of interstitial potassium accumulation probably explains why hypokalemia, or total body K depletion, can actually cause rhabdomyolysis or skeletal muscle ischemia. And again, it's just because you don't have this K-induced vasodilation. So with regards to the kidney and its handling, remember that potassium is freely filtered across the glomerulus. It's mostly reabsorbed in the proximal and thick ascending limb. And it's this component here in the distal nephron where we see potassium secretion. This is the component that is varying throughout the day, and this is the component of K handling that is highly regulated. The three determinants of potassium secretion are shown here. That is mineralocorticoid activity, the amount of sodium being delivered to the distal nephron, and the flow rates that are occurring in that segment. This is a model of the primary cell that's involved with potassium secretion. It's called the principal cell. And notice that mineralocorticoids have a variety of effects. Number one, they increase the activity and the density of the sodium-potassium ATPase. This helps to keep intracellular sodium low so that sodium, as it moves through the epithelial sodium channel, this then creates a negative charge. And it's this negative charge that is a big driving force for potassium secretion. So again, mineralocorticoids are incredibly important in potassium secretion. As I mentioned, you also have to have adequate amounts of sodium being delivered to this segment, because again, it's the movement of sodium into the cell that creates this luminal electronegativity. And this is the real driving force for potassium secretion. The third determinant that I mentioned was flow rate. So under conditions of high flow, this helps facilitate potassium secretion through two mechanisms. One is that high flow will dilute the luminal K concentration, thereby keeping a favorable gradient for movement through this channel called the ROM-K channel. But there's also, interestingly, with high flow rates, there's a second channel that's brought about called a maxi K, or a big K channel. It's actually thought that there exists on this cell a cilium. And when high flows occur, the cilium bends. This then creates a higher intracellular calcium concentration. And that's the signal then for this expression of the maxi-K channel. The normal kidney has a very large capacity to excrete potassium and maintain a normal serum potassium concentration. And I just wanted to make a couple of comments about how this comes about. So for example, under conditions of chronic K ingestion, potassium actually accumulates in the medullary compartments of the kidney, and data show that that accumulation of potassium actually exerts an inhibitory effect on thick ascending limb function, thereby providing more sodium and flow to the distal nephron. There are actually also older studies showing that that interstitial potassium accumulation may have inhibitory effects as well on proximal tubular sodium reabsorption. So again, these two effects then ensure that you have a lot of flow and a lot of sodium being delivered to the K excretory sites to again magnify the K secretory capacity. But I think you have to remember that if this were the sole mechanism, this might be inefficient in a sense, because the proximal tubule and the thick ascending limb are very high salt reabsorbing segments. And so you really would wonder, would potassium accumulation be able to regulate these high transporting segments in a finite way so as to ensure that sodium and flow were just the right amount to cause an adequate amount of K secretion, but yet not be excessive and lead one, for example, predisposed to volume depletion. So given that thought in mind, it's interesting that more recent data has actually shown that the ability of high potassium intake to regulate sodium and flow is very regionalized. And I just wanted to summarize a large body of data depicted on this slide. If we look at the distal nephron, we divide it into the initial portion, which has aldosterone insensitivity. It's not sensitive to aldosterone. And then the second part of the distal convoluted tubule, depicted here as distal convoluted tubule part 2 and the collecting duct, this is where we have aldosterone sensitivity. What is now thought to occur is that when we ingest a high potassium diet, slight rises in the extracellular K concentration, even within the normal range, but higher than normal, high normal range. This is actually sensed through a potassium channel that then causes depolarization of this initial part of the DCT segment. In other words, the cell becomes less negative. Because it's now less negative, there'll be less extrusion of chloride through this chloride channel, and the net effect would be a slight rise in intracellular chloride concentration. The consequence of that is it then alters a number of proteins that regulate sodium transport through the thiazide-sensitive sodium chloride cotransporter. It inhibits it. So in other words, high K intake through slight rises in extracellular K concentration inhibits sodium reabsorption through the thiazide-sensitive sodium chloride cotransporter. In this manner now, you have more sodium being delivered to the adjacent K secretory sites, where we now stimulate electrogenic K secretion, and the higher flow will now stimulate K secretion through this maxi K channel. So in other words, what we're depicting here is the ability of high K intake to cause and regulate K secretion in a very regionalized center, actually all here within this distal convoluted tubule. Some people are calling the distal convoluted tubule a K sensor, if you will. Just to further complete this story, it turns out that high K intake actually is able to initiate potassium secretion by the kidney as early as K entering into the stomach. In fact, there are data to show that as K or potassium enters into the stomach, a signal is actually sent to the distal convoluted tubule to initiate that inhibition of sodium transport that I just described, to then now cause increased potassium secretion in the latter parts of the distal convoluted tubule. So a gastric kidney sensor or signaling mechanism. The exact signal that's sent is not clear, whether it's a humoral factor or a neural factor, but nevertheless, it seems to occur independent of a change in plasma potassium or independent of a change in plasma aldosterone. And lastly, just so that you're aware, potassium exhibits a circadian pattern of excretion. Potassium secretion tends to be higher in the daytime, much less so at night. And presumably this is a teleologic vestige reflecting diet intake. We tend to eat food during the day and not at night. So again, just to summarize, the normal kidney has this very prodigious capacity to excrete dietary potassium, and we now have a lot of insight as to how this occurs. Well, the question arises, how is this normal homeostasis altered in our patients that we see who have chronic kidney disease? So I just wanted to briefly highlight an older study that I think offers a lot of insight. These investigators took a dog model, and the control situation is depicted here on the left-hand panel. That is, the dogs were left with a single kidney, and the other kidney was surgically removed so that all that was left was a remnant. So in other words, at the baseline state, one kidney is intact, and they have a remnant other kidney. Notice that after the surgical procedure, the plasma potassium is largely normal, but most of the urinary potassium is being excreted by that normal or intact kidney, very little by the remnant. Now, the experiment is you take out the normal kidney so that all this animal has left is the remnant. And notice that within 24 hours, that remnant now has a 4-fold increase in its ability to excrete potassium. The blood potassium hardly changes. And by several days later, there's a 6-fold increase in the potassium coming from the remnant. And all the time, the plasma potassium is barely altered. What we're seeing here is what we've learned about in our medical school days. That is, in general, you should not see problems with potassium in people who have chronic kidney disease until the glomerular filtration rate falls to around 15 or 20 mLs per minute. In other words, severe reductions. And the thought is that the remnant nephrons undergo adaptations so that each individual remaining nephron has a higher capacity to excrete potassium. And this presumably protects us from developing hyperkalemia until very late in the evolution of chronic kidney disease. Now, notice, to be sure, the reserve or the ability to handle a challenge of potassium is markedly attenuated. If we take these animals who have the remnant and infuse potassium as a challenge, notice the rise is much greater and the time that it takes to normalize is much longer as compared to the normal animals. So the reserve is clearly much less with developing chronic kidney disease. Now, despite the fact that we've learned that you should not get hyperkalemia until severe reductions in the GFR, I think we've all seen clinically where we have encountered patients who may have much more preserved GFR, and yet they're already exhibiting hyperkalemia. Whenever that's the case, you need to then consider, is there one of three abnormalities present? One abnormality would be a primary decrease in distal sodium delivery. So in other words, somebody who has decompensated heart failure, for example, they can develop hyperkalemia very early on because they have limited the amount of delivery necessary to establish that negative charge in those remaining nephrons. Another cause of early onset hyperkalemia would be a primary decrease in mineralocorticoid activity. And a third abnormality that can cause early onset hyperkalemia is disease states that primarily target the collecting duct, for example, tubulointerstitial chronic kidney disease. Here we see hyperkalemia occurring quite early. So how do we manage hyperkalemia, particularly keeping those three causes of early onset hyperkalemia in mind? The first thing I wanted to mention is that whenever you see somebody with an elevated potassium, it's useful to review the medications that they're receiving and see if there is something that you could remove that might be causing problems. So most of the medicines and disease states that I will describe are those that affect the renin-angiotensin-aldosterone axis. Remember, aldo, as we talked about, stimulates sodium movement. That creates that negative charge. That's the driving force for potassium secretion. And so anything that interferes in the activity or formation of aldosterone, starting right here with the release of renin, is going to cause hyperkalemia. And so we have a number of drugs and disease states that can impair renin release. Perhaps the most common one is administration of NSAIDs, non-steroidal anti-inflammatory drugs. It turns out that prostaglandins stimulate renin from the JG cells, and when you inhibit those with NSAIDs, renin falls, aldosterone falls, and you get hyperkalemia. Beta blockers can suppress the release of renin because adrenergic nerves normally regulate renin release. The calcineurin inhibitors used in transplant can cause suppression of renin. The diabetic patient has hyporeninemic hypoaldosteronism, likely because they get microvascular disease of the afferent arteriole. And interestingly, elderly subjects are more at risk to get hyperkalemia because there's an age-related decline in the ability to make renin. Once again, if renin is low, the downstream products are low and K secretion is impaired. We have one drug that inhibits the enzymatic activity of renin called aliskiren. It's an antihypertensive agent. It's not used that much, but you should be aware of it. The ACE inhibitors block the cascade here. Angiotensin II and aldosterone levels are lower. That's why they cause hyperkalemia. The angiotensin receptor blockers block the AT1 receptor on the zona glomerulosa cells of the adrenal gland, thereby lowering aldosterone. We have processes and drugs that interfere in aldo metabolism. In addition to intrinsic adrenal disease, don't forget about heparin and the azole antifungal ketoconazole. these latter two drugs actually reversibly interfere in aldosterone biosynthesis. And then we have some drugs that block the aldosterone receptor, spironolactone and eplerenone. But also remember there's a progestational agent called drospirenone. It's found in several birth control pills. And so it's actually useful to look at the package insert of those birth control pills and see if it contains this agent. Imagine that you're treating a young diabetic woman with an ACE or an ARB for kidney protection, but you want to guard against the teratogenicity of those drugs. So you ask your OB-GYN colleague to prescribe a birth control pill. If that agent contains drospirenone, when you combine it with ACE or ARB, you've additively impaired this system and you make the patient at risk for hyperkalemia. Lastly, things that block the epithelial sodium channel like amiloride, triamterene, the antibiotic Bactrim. These will interfere in sodium movement and you'll lose the negative charge. This can cause hyperkalemia. The next thing we want to do is restrict dietary potassium if we have early onset hyperkalemia. And I actually put here dietary counseling. Remember that this actually comes with a downside. It turns out that the foods that are most enriched in potassium tend to be fruits and vegetables. And those actually have health benefits. They're heart healthy. In fact, fruits and vegetables may have a favorable effect on chronic kidney disease progression because of the alkali load. This was data from a Korean study recently published, and notice that those individuals that had the highest urinary potassium to creatinine ratios, reflecting more fruit and vegetable intake, had slower rates of decline as compared to those who had lower amounts of potassium in their urine, presumably reflecting less fruit and vegetable intake. Similarly, even in dialysis patients, notice that individuals who are ingesting more fruits and vegetables had greater cardiovascular better cardiovascular outcomes compared to individuals who were eating less servings of fruits and vegetables. So the point of this is that, yes, we want to counsel patients about foods that might be particularly offensive and causing hyperkalemia, but do be aware it might come with a downside because those foods that have a lot of potassium tend to be heart healthy. And so we want to balance the risk and perhaps be a little bit more nuanced on what we actually tell our patients to restrict. The third strategy I always like to employ is using good diuretic therapy in our CKD population. When people have GFRs of less than 30 and they require diuretics, for example, in the management of hypertension, loop diuretics become required. Diuretics are quite useful in ameliorating the risk for hyperkalemia because they induce higher flow, they provide more sodium to the distal nephron, and again, this enhances K secretion. Correcting metabolic acidosis, if it's present, also favorably affects the risk. It does so by raising the bicarbonate, you'll shift K into cells, and also the higher sodium load will help facilitate K secretion distally. We can also consider decreasing or lowering the dose of a renin-angiotensin system blocker. That will have a favorable effect on potassium. But once again, this comes with a downside. As I think most people are aware, ACE and ARB therapy is quite beneficial in heart failure. It can lower mortality risk. In chronic kidney disease, these drugs slow the progression of CKD. So once again, you have to balance the decision. On the one hand, you can lower the risk of hyperkalemia, but then you give up the benefits that these drugs may be providing on cardiovascular benefit. Well, that brings us to the idea of managing hyperkalemia with the use of binding agents, and I wanted to spend a little bit of time on this. Now, for the last 50 years, the only drug that we really had available that was a potassium binder was sodium polystyrene sulfonate, or KXylate. And basically, as shown here, this drug works by binding potassium, in exchange for sodium. So you get a lot of sodium absorption because you displace the sodium from the resin. I would like to make the case, though, that K-exolate is a very poor potassium binding agent. The affinity for the resin is actually greater for calcium and magnesium, and it's equal to ammonium in the GI tract. This study, I think, nicely shows that most of the potassium lowering effect with K-exolate, or sodium polystyrene sulfonate, is actually due to the sorbitol that K-exolate is frequently co-administered with. Notice that in this study, if you give somebody sorbitol, they get diarrhea. There's an increase in stool water, and this then accounts for some of the potassium output from the body. Notice in this study, if you added 30 grams of K-exolate to the 60 gram sorbitol, there's virtually no additional potassium output. If we give 120 grams of sorbitol, there's a little bit more potassium output, but notice that when you add 30 grams, virtually no change. So I would like to make the case that with K-exolate, the vast majority of the potassium lowering effect that one sees is the increase in stool volume brought about by the osmotic agent sorbitol. Sodium polystyrene sulfonate is really not a viable agent for chronic use because it's very poorly tolerated. And as this slide summarizes, and you can read it, there are many reports now of severe GI toxicity that can occur. And so given the poor tolerability and the lack of efficacy, we really have needed a new type of binding agent that would be better tolerated and, more importantly, be effective. And we now have two such agents that I just wanted to briefly mention. One is called Patiromer. It's a polymer that exchanges potassium for calcium. It does carry with it a warning that you should separate it by 3 hours from other medications. The most common adverse event is occasionally some GI intolerance, most commonly constipation. About 5% of patients get hypomagnesemia. It's never really been studied in people with bowel disease. They were excluded from trials, but this is a very effective agent. The way the drug works is as follows. Remember, in the colon, we have two routes of potassium secretion. One is an electrogenic mechanism shown here through creation of a negative charge. There's also an active K secretory process. And then at the last part of the colon, we actually have some K absorption. So when you take this polymer, Patiromer, as it goes into the colon, it starts to bind potassium. And by binding potassium within the lumen, this then facilitates K secretion through this passive mechanism, and it also facilitates a favorable gradient for the active mechanism. Also, by binding potassium in the GI lumen, it limits the amount of K that can be reabsorbed through this HK-ATPase. As I mentioned, it does release calcium. Most of that calcium is bound to carbonate and phosphate and then excreted in the stool, but there is a small amount of calcium that can be reabsorbed. Lastly, as I mentioned, there's a little bit of magnesium that seems to be bound, and about 5% of people in the trials developed hypomagnesemia. This just shows some data regarding Patiromer. If you take mild to moderate hyperkalemia, and you can see that over a 4-week period, administration of the Patiromer nicely controls the plasma potassium. Of note, 100% of these individuals are receiving RAS blockade. George Bacris did a long-term study where patients were treated with the drug for 1 year. And again, notice control of the plasma potassium, despite 100% of these subjects using ACE-ARB therapy. So these studies are at least suggesting that these binding agents could be a way to facilitate the use of ACE or ARB therapy in people who need to be on those types of drugs. Lastly, I would mention this study, the AMBER study. People who had drug-resistant hypertension were randomized to either receive spironolactone with the Patiromer or spironolactone by itself. And you can see at the end of the 12 weeks, more people were maintained on spironolactone who were also receiving the Patiromer because you could protect against the development of hyperkalemia. The second agent I briefly wanted to mention was sodium zirconium cyclosilicate. This is a crystalline structure that's highly specific for the potassium ion. It's quite effective and rapidly acting. It is recommended that you separate this drug by 2 hours from other medications. The most common side effect is a small amount of edema, thought to be due to the fact that as it binds potassium, you do release a little bit of sodium. Just some data with regards to the zirconium product. If you take patients who have hyperkalemia, you can see that there is a rapid initial drop. The first statistically significant time point is 1 hour. And by the end of the 48 hours, over 90% of the subjects are controlled. This study by Spinowitz and colleagues showed that ongoing administration of the zirconium can result in control of potassium over a 1-year period. In this trial, about 2/3 of patients were receiving either ACE or ARB therapy. So again, another binding agent showing that you could facilitate the use of ACE or ARB in people who may be needing those types of drugs. Fishbane and colleagues have actually tested the use of zirconium in dialysis settings. This was a study of patients who had pre-dialysis hyperkalemia who were either treated with zirconium or placebo. The drug was given on non-dialysis days, and notice that you could control that pre-dialysis hyperkalemia as compared to those who remained on placebo, and you did not worsen the post-dialysis potassium concentration. So again, it's a way that you can address the problem that we as nephrologists frequently see, and that is this persistent hyperkalemia right before the dialysis treatment. Here we see the 3 binding agents stacked up against one another. So again, the K-exalate, this is what we had for 50 years, poorly tolerated, not very effective. But these 2 new binding agents, very effective. The Patiromer exchanges a little bit of calcium. The zirconium exchanges a small amount of sodium, but both very effective agents. So let me just summarize by saying that hyperkalemia is common in clinical practice. Remember to always look at medications, good diuretic use, correct metabolic acidosis. Restrict foods, but in a nuanced way. Remember, there is a downside of just totally forgetting about fruits and vegetables. Sodium polystyrene sulfonate, it's poorly tolerated. And we now have new agents, both Patiromer and zirconium cyclosilicate. These drugs may in fact allow facilitation of the use of RAS blockers. So again, I'd like to thank you very much for your attention, and I'll be more than happy to answer any questions.
Thank you, Dr. Palmer, for a very interesting, thorough talk to take us through the nature of hyperkalemia and the mechanisms by which hyperkalemia happens, and highlighting that a review of medications that you've reminded us all of the various medications, where they work, and how they might contribute to hyperkalemia, or actually how they may also resolve hyperkalemia or work towards reducing hyperkalemia. And while there's some debate about the level of potassium at which we should be concerned, I do appreciate your comments on the dietary counseling, and thankfully we have a good amount of clinical dietitians in the province to guide our patients through that. And also your comments on sodium polystyrene sulfonate or K-exalate or Solistat, and how it may be the sorbitol that's providing the action. And finally, thanks for talking about the new drugs and where they may fit into our therapy. And I understand that due to unforeseen circumstances, Dr. Palmer can't join us right now to answer your questions. They are coming through. And trust, though, that when this talk is posted for your viewing again, and maybe again and again, we will have Dr. Palmer address your questions. We have questions from the audience asking about what his preference is between the two newer agents, and the palatability of these newer agents. So these are all important questions. Certainly the patient experience and patient preference comes into it. We do know that a number of patients don't prefer taking KX-late or Solistat. And with that, we will be evaluating these therapies as they are either in BC or coming to BC very soon, and looking at the indications for use and the cost and the evidence. But I think it helps to have that background knowledge of the various things we can do currently to address hyperkalemia, and how these new agents might come into practice and be used should we add them to our formulary. So with that, I'd like to thank you for attending, and hope you found the talk to be as interesting as I did, and to thank Dr. Palmer once again for enlightening us and spending time to give us this talk today. Thank you very much.